On to the second talk. Who is fit for refractive, surface ablative versus flap procedure, what to do and not to do. I invite Dr. Aysha. She's a refractive surgeon at Srikanth High Hospital, Kozhikode. Over to Aysha.
Thank you, ma'am. Good morning, everyone. I would like to thank KSOS and the scientific committee for giving me this opportunity. Today, I'll be giving a brief explanation about surface ablation with flap procedure, in that what all we should do and not to do. So we all know there is three types of refractive error: myopia, hyperopia, and astigmatism. Same way, we have three modalities of treatment of refractive error. In that, eyeglasses and the contact lens is a temporary mode of treatment. That is, once the eyeglasses or contact lens is taken, you will have a blurring of vision. For that, we have a permanent treatment method called refractive surgical procedure. So in the refractive surgery, we have a two type, that is a lens-based procedure and a cornea-based procedure. In the cornea-based procedure, I'll be mainly discussing about the tissue subtraction method like a surface ablation like LASIK, and a stromal ablation like surface ablation like PRK, and a stromal ablation like LASIK. So the main mechanism here, the refractive surgery or the laser, is photoablation. That is, it breaks the carbon-carbon molecular bond in the stroma and thus it reshapes the corneal surface. Excimer laser used here is the argon fluoride excimer laser with a flying spot size of 1 to 2 mm, energy of 100 to 300 millijoules and a pulse of 100 to 1000 hertz. Whereas photodisruption is mainly done for femtosecond laser for creating a corneal flap. So before going for refractive surgery, you should attain a certain rules. That is, always set a realistic expectation. Time taken for vision to improve, especially in PRK patients. Minimum you have to tell them 3 to 4 weeks to get a crisp and clear vision. Dry eye. In the preoperative method, if patient is having dry eye, tell them the need of long-term lubricant, especially those patients whose screen time post-surgery is 5 to 6 hours. Tell them they have to use preservative-free lubricating drop for another 3 to 4 months. And refractive predictability within plus or minus 0.5 diopter before the surgery itself, you will tell the patient. The need for presbyopic glasses, and the most important is the patient cooperation during the procedure. And 5 points when patient is in the intraoperative, under the table, 5 points you should tell before itself. Before a patient is counseled for PRK or LASIK, explain to the patient what is PRK, what is LASIK, what procedure you are doing for PRK, what procedure you are doing for LASIK. First point is touch. Patient, tell them, though we put a paracaine to the patient, you will feel a touch, but they will not have a pain. Especially when the suction and the blade movement, patient, tell them you will have a feel of touch. Sight, when the patient is under the machine, tell them to look on the light or the red light or the green light. Once it is focused, tell them you should not move, because during suction process, there will be slight blurring. So chances of patient to the light move and focus to the light is more. Third, sound. Tell them you will hear a sound of a blade sound or excimer laser sound. Nothing to panic, just tell them to calm. Smell. Nowadays, because of the latest machine, you will not get that burning smell, but few machine you will get that excimer vapors burning smell. Calm mind. That is the most important thing. Before coming to the OT, ask the patient whether they have a claustrophobia. If not, it is good. If, tell them nothing to panic. Procedure hardly takes to 10 to 15 minutes. Before starting the procedure, make sure your patient is calm. Now I'll be dealing with photorefractive keratotomy. That is, by using the excimer laser, we mainly reshapes the anterior surface of the cornea. So who are fit for PRK? Any low to moderate myopia with 6 to 8 diopter, low hyperopia up to 3 diopter, moderate astigmatism up to 4 diopter, thin cornea where RSD is less than 300 micron and are not fit for LASIK, deep orbit with suction is not possible in LASIK, flat K less than 40 and a steep cornea greater than K 48 where the blade complications or a flap complications will be more. Any sports person or occupational person like Navy, Army where chances of flap trauma is more, and any enhancement procedure. So surgical step combining with PRK and LASIK, here the most important part is the epithelial removal. That can be done by mechanical, where manually we are scraping the epithelium by using a hockey knife, or chemical by using 20% ethyl alcohol, and the latest technique is the laser method. Once epithelium is removed, we'll do the excimer laser ablation. After that, we have to apply mitomycin C for 30 to 40 seconds depending upon the refractive power. This mitomycin C is thoroughly washed with balanced salt solution. Finally, we have to place bandage contact lens with appropriate antibiotic coverage. So the first picture you can see, that is alcohol well, where alcohol is put 20% for 20 seconds. Second picture is a trans PRK, where laser itself will take the epithelium. You can see a clear margin while combined to the third picture, where we are removing manually. This is a small video how epithelium is removed by using alcohol. That is an 8.5 mm gauze piece, absorbed gauze, soaked with 20% alcohol. I'll be placing for 20 seconds. This is 20 seconds. Then delamination of the epithelium will be done. Slowly by using hockey knife, gently remove the epithelium to get the clear 8.5 margin. Make sure you should not force or you should not apply force in this. Sorry. This is how epithelium is removed. Once this epithelium is removed, the next step is the laser ablation. So in this, before going for laser ablation, what you have to do is the iris registration. The benefit of this iris registration is there won't be any decentered ablation if the patient moves the eye a little bit. So once this is done, excimer laser is given, then a mitomycin C will be placed, a thorough wash is given, and a bandage contact lens is placed. So what are the post-operative care? Do not touch or rub the eye. Follow up post-op medications properly. No face wash or a hair wash for 5 days. No eye makeup for 2 weeks. And no swimming in lakes, beach, pool for 1 month. So next is LASIK or femto. Both are flap-based procedure. In LASIK, to take flap, we will be using microkeratome, whereas in femto, we will be using laser. So flap-based procedure is mainly done myopia up to 8 to 10 with a proper corneal thickness, astigmatism up to 6 diopter, and hyperopia up to 4 diopter. So this is the most important step in LASIK, the selection of the microkeratome. We have a different types of microkeratome. So always try to keep the K mean around 40 to 46. So less than 41, there is a chances of free flap. Greater than 46, there is a chances of buttonhole. Thinnest Pachy, you know, it should be 500, and the final RSB should be always 300 microns. This is a small video. Once a suction is given, this is how the blade is moving. That is a forward movement. And same way, you will have the backward movement. So once this is done, carefully we have to remove the instrument, and the next step is the flap lift. So after the blade is given, you can slowly go under the flap, lift, keep it in the tacho fold. Once this is done, go for the excimer laser ablation. Keep the flap opposite and a bandage contact lens. Make sure the flap is aligned properly. So femto-LASIK means femtosecond laser will be there for the flap creation and excimer laser for the stromal ablation. Here main difference is we have to dock the patient eye with the cone. So this is the docking of the patient, this is the cone size, and the cone size depends upon the wide to wide measurement of the cornea. So post-operative complication, pain, PRK, especially in PRK. Before going for surgery, explain to the patient pain, watering, photophobia, redness. These 4 symptoms persist for 3 days. Second is epithelial problem. Next is corneal haze. And intraoperative complications like free flap, buttonhole, flap tear, epithelial ingrowth, debris, microstriae, infectious keratitis. Dry eye is the most common problem, especially seen in the LASIK. We go for preservative-free lubricating drop. Glare, halos, and starboard. This is other most complications seen in the LASIK. Decentered ablation, overcorrection, undercorrection, and regression is another complications of LASIK and PRK. So finally, I am ending. PRK can be done with thin cornea, high keratometric reading, narrow palpebral aperture, patient at a high risk of blade trauma. LASIK myopia up to 8 diopter, hypermetry up to 6 diopter, astigmatism up to 6 diopter, and residual refractive errors after cataract surgery and PK.